Good afternoon, everyone. Welcome to the sixth session of the National Commission to Address Racism in Nursing, the fourth ECHO series. This series is a focus on health equity. Whether you have been involved in previous ECHO sessions or are new to this space, we are excited to be here and hope this interactive learning series is a place for you to find guidance and support. This program is brought to you by the National Commission to Address Racism in Nursing, a multi-organizational collaborative of leading nursing organizations examining the issue of racism within nursing and motivating all nurses to confront systemic racism. This is an 8-part series. You will earn 1.5 nursing education units for attending today's session. Please stay to the end to complete your evaluation and receive the CNE certificate. Today's topic is Dignity and Cultural Humanity in Care, Setting the Foundation for Achieving Equity. Before we go over the ground rules, we wanted to quickly orient you to some of the features of the new iEcho platform that we are using. You can review session materials within your iEcho account in the content section outlined in green here. Within each session, presenters will upload their slides and any other relevant materials here for you to use. There is a conversation tab found within the discussions tab circled here in yellow. This is meant to be a place where you can engage with other participants in the series. Please note, any questions directed to ANA staff or anything that is time sensitive should be sent via email to commissiononracism@ana.org. And also, if you are having any technical issues, please also email us. We want you to note that we have had an overwhelming response to the ECHO series. Consequently, we have larger than desired breakout groups. Please bear with us. Although this is a great problem to have, it means you will need to be patient with our incredible volunteer breakout group facilitators and the other participants. Please use the raise hand feature to be recognized. Keep your comments concise, or place your comments in the chat to be part of the discussion, and this will lead to a positive experience for all participants. Please pay special attention to our ground rules as we learn and engage with each other today. Note that we will be turning off the chat during the didactic portion of today's session, but you will still be able to message the co-host directly if needed. This is a brave space, and discussion racism and health equity is difficult and uncomfortable, especially for those directly impacted. Discussions such as these can serve as a trigger. We ask that you maintain respect for everyone joining us today. Please stay on mute until it is your time to speak. Listen intently and respond thoughtfully. Be present. Limit background distractions and multitasking. Please take advantage of the virtual features via Zoom. We encourage you turning on your cameras and using the chat box or the raise hand features to communicate with the group. But remember to mute your microphone when others are speaking. Please respect participant privacy. Do not disclose names or other sensitive information that's shared. If you share a scenario involving a patient, do not provide any personal information during today's call or any of the ECHO sessions. Feel free to directly message us should you have any technical problems. I am now going to turn over the presentation to Dr. Tyonne Hinson.
Thank you very much. It is great to be here, and so I'm excited and thank Dr. Ruth for that wonderful introduction, and just really to be here today. And so I'll begin to share my screen and jump right into the presentation. So, as shared by Dr. Francis today, we are here to talk a bit about dignity and cultural humility in care. And I am really, this is a topic that's very near and dear to me, given the work around the work that I do as a nurse, and also my focus as a public health practitioner. And so I was really humbled and honored to be asked to talk a bit about this and really to be with you today and sharing some of the ways in which I have over my experiences and also in working at Bay State Health, a health system in Springfield, Massachusetts, and the greater Springfield area to really focus on setting the foundation for achieving health equity in the work that we do here. So as an individual who has been a nurse for over 25 years and really focusing on the work of focus of Project Echo and this year's focus of 3.0, I'd like to start really with understanding and helping you to understand the key desired objectives for today's journey. This is such a critical topic today, particularly as more and more light is shed on the national needs related to health inequities, specifically for those of Black and Brown descent and backgrounds. For a long time, we have known about several of these inequities. However, since the pandemic, there has been a considerable amount of attention that has been shed through media, as well as through written research and articles. And so the goal is to really close the chasm related to these specific areas, particularly for minoritized races and populations, and really close the gaps in understanding how care is delivered and the outcomes that are experienced by those particularly in racism and the systems that are impacted by structural racism in our healthcare systems in our communities. This is also critically important for some of you as you are going through potential introductions of waivers in your states related to health equity and quality. I happen to be in Massachusetts, which is the first state to really adopt a 5-year waiver focused on health quality and equity. And this focus is really not only going to change the way that our healthcare is delivered for all populations, but it's going to definitely close the gap in inequities and really the experiences that populations of color have. And so the goal today is to give you and arm you with some of the tools that you will need to confront the systems that are creating inequities in health and really taking on head on some of the pieces related to structural racism and race in healthcare that is impacting the outcomes that you are seeing and the experiences your patients are having. So these objectives, and there are 5, we're going to increase your knowledge of creating an inclusive culture, basically through understanding the foundational constructs of cultural humility and dignity, introduce 10 essential elements of the dignity model and dignity in care, define cultural humility and the elements that really bring along that construct and the journey towards humility from a place of cultural competence, and also understand the impact of bias and that of structural systems and influence on healthcare outcomes and racial disparities. And then lastly, we'll talk about ways to honor dignity of all people and really call into question when you see individuals not honoring and respecting the dignity of individuals or recognizing who those individuals are as people and populations. So we've gone over some ground rules, but I just wanted to share this particular ground rule deck or number of statements that we have brought together here at Bay State Health related to the foundation of the dignity model, which we'll talk about today. And so you'll understand a bit more of the meaning around these statements when you begin to learn about the dignity model. But these are really elements that come from a space and place of elevating one's self-dignity as well as honoring the dignity of others, and also really setting the stage for allowing others to speak without, again, retribution sharing what it is that they understand or fear, and also really understanding and sharing that if you violate anyone's dignity in any statement or any way that you may share, that you will find time to either apologize or give space to right the wrong, which is one of the 10 elements of dignity that we will talk about. I also want to share that these are topics that may be difficult to talk about. They also may bring up past experiences that you may have had. And so I just want to share that it is okay for us to be authentic and really have transparent conversations while also making this as psychological and physically safe for everyone here. And so that is really important to me as we're having this discussion today. So as we jump into this topic, there are many dimensions of health equity, and I want to honor that and share that and recognize it in this conversation. And in this circle, you see there are many pieces that come up, whether it's health equity related to mental health, our gender, our society, spaces of other disparities and difference. And so we recognize that race is not the only dimension in which health equity is a construct of that discussion, and that there are many others. And so in order to give space for that, we want to recognize that in our LGBTQ and transgender space, we see disparities and challenges of equity related to the delay and also the seeking of medical care, as well as not getting the care and the coverage necessary in the community. In the space of women's health, we understand the inequities that exist related to maternal outcomes, particularly for those of Black and African American women, regardless of education, and also the experiences related to the existence of mental health and depression, behavioral health existence, as well as some of the inequities that exist among populations of color when we're looking at the rates of some cancers in women's health. We also recognize the space of health equity in aging and ageism, and understanding the challenges that come along with the isolation, access, and many aspects related to health inequities around really honoring the care that's necessary in this particular population, and the challenges related also to financial security and access. And lastly, we don't want to forget to honor and talk about the disparities and the health inequities that exist within the space and place of individuals living with disabilities, and recognizing that there is a tremendous aspect of health disparities related to delayed care, lower likelihood of preventative care, and higher incidence of tobacco use, obesity, and high blood pressure. But today we're here to talk about health equity and race. And I raised to you this quote that I read as we are thinking about this specific topic. Why are Black people sicker, and why do they die earlier than other racial groups? Many factors likely contribute to the increased morbidity and mortality among Black people and brown people. It is undeniable, though, that one of those factors is the care that they receive from their providers. Black people and brown people simply are not receiving the same quality of care and their white counterparts and others receive. And this second-rate healthcare is shortening their lives. And so as I read that quote, it really stuck with me, and thinking about all of the seminal pieces that has come before. And when we think about back all the way to the Institute of Medicine, and them basically sharing in their 2005 work, the realities that racial and ethnic minorities do receive a lower quality of healthcare than white people, even when their insurance status, their education, their age, and their severity of conditions are comparable. And so we find that those numbers and those rates and those experiences back in 2005 are the same experiences that we are having today, if not at a higher rate. and the chasm has not been closed, but instead, in some spaces, it has widened. And so why is this? Why is it that minority persons or minoritized populations are less likely than white persons to be given appropriate cardiac care and treatment, receive kidney or dialysis or transplants, and receive the best treatment for stroke, cancer, and other significant health equity and situations and diseases? And so the reality is racial disparities and equities in healthcare is not a new topic. And so this is something that we have to take on head on, and we have to be willing to have these conversations and understand the systems that have created this within healthcare. It is vital for us to continue to understand this and continue to work to close the gaps according to how we will then change bias and change the realities of disparities in healthcare. And this comes through education, knowledge, and really cracking the code, if you will, around changing how our systems work and ultimately changing the actions and the interventions we deliver. And so this is a model from the World Trust that I introduced related to the systems of racial inequity and bias. And so this system and model frames the self-perpetuating system of racial inequity. You have a section that really focuses on social determinants. And so that is related to our history, identity, and our culture. And so that's one when you look at the outer section of this model. Then you have section 2, which is around the internal components, which really in those internal components come the realities of bias, privilege, and internalized racism. And then the third component and section of this relates to the external relationships, which are about interpersonal, institutional, and structural, which we'll talk more about. All of these layers are happening at the same time. And subsequently, they're turning into and impacting the inequities that we are seeing in health, as well as in other systems that are impacting the outcomes of Black and Brown populations. And so basically, sometimes this is oversimplified in saying that there are stereotypes. We all have these thoughts. We all have senses about what this model or what individuals bring into this that impact themselves. But what we have to recognize is that all of these elements come together and create a dynamic really focused around power and economics. And at the end of the day, these really then cause the bigger system and create the bigger system of racial inequity and bias, which then trickle into and health outcomes. So I mentioned 4 elements previously, and I want to go a little bit more into those elements related to the 4 levels of racism. And this will be important for you to understand as you're beginning to think about confronting and being able to take on the inequities and take on the systems that you will use to change within your healthcare systems, within your organizations, within the teams that you lead, and also among your colleagues. You have to understand these in order then to move into a space and place related to this work. So the first is really around internalized racism. And so internalized racism is that of racism that is really internal. So it's when a person themselves accepts a negative stereotype or feeling or message about their own selves or about the cultures in which their systems, their belief system is. So really that one image which has all the brown faces is intentional because it's talking about what are the pieces that maybe brown people or Black people believe about themselves that may cause you in and of yourself to view something yourself as inferior and something else as superior. So an example of this would be viewing white skin or light skin over dark skin as or really then also trying to lighten maybe your own skin. So that's an internalized piece of racism, and really thinking about then how that impacts the way that you view the world based on the pieces that you believe about yourself or about others within your race. We then move to interpersonal. And so interpersonal racism comes into play when a person's conscious or subconscious racial influences their interaction or their perceptions of other people. And so in this space, this comes into selection bias. So you notice the person reaches down and picks up the person that is like them. And so this is really about a subconscious racial bias that influences your interactions. And it doesn't happen with one subset of people, it can happen with everyone. It's really about your conscious or subconscious of selecting people that are like you, or having interpersonal thoughts about people unlike you or different than you. And so that's the key piece of interpersonal. As you move to institutional racism, this is also can be seen as systemic racism, or is known as systemic racism. And so this is about the implicit or explicit rules and regulations within an organization that discriminate against marginalized communities. And so this can manifest as bias, or it can manifest as action towards a certain group of people. So specifically in healthcare, this could play out as the common perception, or what is shared, that doctors are more likely to favor potentially white patients over Black patients, or stereotype Black and brown patients as being more difficult, or using the terminology of being medically non-compliant, when in fact there may be other social determinants of health that are influencing the actions of Black and brown people, or reasons why they may not be able to make it to their either appointments or get their medication. And so thinking about that. And then the last piece we talk about is structural or systemic racism, systemic racism, which really refers to our biased laws, our policies, our practices that restrict people, access, and opportunities. And so most of all, as we think about this systemic racism, we're thinking about much larger pieces. In healthcare, it would be medical algorithms. It could be really, and thinking about historical pieces of redlining, mass incarceration. I would say, as we think about other pieces, such as the GFR, pieces that we've seen now in medical literature that's been coming out, and also for pediatrics, even smaller pieces of the algorithm related to febrile, the care of the febrile infant, and having pieces related to scoring based on skin tone and color and aspects related to race. So all of those things really play out in health inequities and inequality. So as we move to a place of thinking, how do we change and move the dial on this? And also reflecting on where we've come from. And I really wanted to reflect on this quote of Martin Luther King that goes back to, of all the forms of inequality, injustice in health is the most shocking and inhuman. And I also want to share that spending time with this in preparation for today, you will notice that we often hear this quote stated as most shocking and inhumane, but in fact, it was inhuman. And as I looked more into this and what Dr. King said and the reason why, he talked about it being inhuman versus inhumane, because inhumane suggests a lack of compassion for human suffering or pain, whereas inhuman is a more extreme form of that, suggesting a denial of humanity that is so cruel that it is or should be beyond human action. And so when we think about race and systemic racism and healthcare and health inequities, that is or should be beyond human action. And so it is important for us to take the steps necessary to move to that place where we are taking it head on and changing the systems so that we rid ourselves of injustice and inequities in healthcare. So how do we do that? We use the dignity model, which was introduced by Dr. Donna Hicks, who created this as an author, researcher, and professor focused on work that she had done throughout much of Europe and the BBC, and really in working with victims and perpetrators in various conflicts, with Northern Irish conflict and Archbishop Desmond Tutu. And this model really works really in helping resolving international conflict, but also in thinking about how you simply resolve conflict between humankind and how individuals, regardless of their background, regardless of their race or who they are, how they want to be treated. And that is always in a dignified way. And so the dignity model basically brings to light that every human has inherent value and worth. And this is how, regardless of background, race, or who we are, we should approach every patient and every individual that comes into our healthcare system or comes to us for care in that way. We also must recognize that no one can take dignity away from a person, and no one can take dignity away from us. And so as we're working with individuals to help them understand that, this is a tool to help communicate and help you to communicate this work, that no matter where friction lies or what is brought to awareness around our own vulnerabilities, we can always go back to the 10 elements of this. So see this really as a fundamental model to beginning to unpack and dismantle the actions and behaviors that create oppression, inferiority, racism, and health inequities. These are also necessary to begin to look within and have conversations about what you do not know when you have been incorrect or when you need to move to a place of better understanding. So these are the 10 elements, and I'm not going to go through each of them, but what I will share is that there are some key elements here, particularly sort of in these discussions, that focus on acceptance of identity. So no matter what your background is, what you look like, your community, really accepting everyone as an equal and do no harm to your patients. The concept of acknowledgement, giving everyone your full attention and validating that you hear their concerns and what they have gone through when they're coming to you, and really listening to understand them, which understanding is key in the relationship of caring for an individual and having that growth mindset. And understanding that if you didn't know something or you didn't inherently agree with it, that you're going to do the work to learn how you can better understand a perspective. And also giving benefit of the doubt and righting the wrong, which is not only helpful for the individual related to actions you may have done or maybe spoken, but it also helps you to regain your own dignity in a situation where that may have occurred. And so many of these elements are really used fluidly throughout our interactions, but they are key in really understanding specific interactions in race and really approaching and changing the narrative as you are in your clinical settings or in your communities to make a difference. And so dignity really requires the consciousness and thinking about these three aspects of connecting with your own dignity, connecting to the dignity, value, and worth of others, and connecting to the dignity of something greater than ourselves. So thinking about our colleagues, thinking about our patients, reflecting on the mission and vision and values of our organization, our spirituality, and our community, but also recognizing your own inherent rights and value and worth. And as leaders in healthcare and laying the foundation for colleagues, we have a primary requirement and a responsibility to remember these pieces and bring them to shift the culture in our discussions, in our behaviors, and our understanding. But first, it starts with you and owning yourself, your own self, understanding your own self-dignity, and then connecting with others. As you're on this continuum and journey, and bringing us from a space of cultural competence and moving to a space of cultural humility. Dignity is the first foundational piece, but getting to a place of achieving health equity is really foundational to achieving the aspects of movement towards cultural humility. And so there are four primary dimensions in this work, and I'm sure many of you are familiar with this work of Teverlan and Mary Garcia. That really goes back to 1998. But this piece of cultural humility really incorporates a lifelong learning around commitment to self-evaluation and critique, to redressing the power imbalances that exist between the patient and health provider dynamic, also to developing mutual beneficial and non-paternalistic partnerships within our communities on behalf of our individuals, our patients, and defined populations. And so this is a goal that everyone should have, because we're all in the continuum of moving from that place of cultural competence to cultural humility, but understanding that cultural competence is foundational. So if you hear someone in your policies or in something say, we're moving to a place of being culturally competent, that's not enough, because that will not get us to a space and place of stamping out inequities within our healthcare systems. We need to be taking and owning the steps of these four domains and really taking learning further in an ongoing way that allows us to practice and better understand within our organizations and change the power imbalances and reduce the barriers to make our systems better for all. And so this is an example from the conceptual analysis of cultural humility that really puts into, I think, a showcased way of understanding how this works and how the layers fluidly interact with each other. There's a movement that implies one must strive for continuous learning at the highest level of learning, which is lifelong. So you see lifelong learning there. It is transformational. It involves a change in an overall perspective and a way of life. And it is a way of being. So the way of being is that you're open, that you are self-aware, that you check your ego at the door, that you are supportive in every interaction, regardless of what your title is, or regardless of what you may represent as a person, a population, and who your patient may be. And recognizing that you have an obligation to really self-reflect on your actions at all times and critique, and also being reflective of your actions as well as colleagues and as peers and as leaders in our environment. This process does not happen overnight and will not happen immediately. It is fluid, it is constant, but it is speculated that over time, with education, reflection, and effort, progress can absolutely be made. And so it is about empowering ourselves, empowering our teams, and creating those partnerships so that we can create optimal care and respect for our patients and our families. As I come to a close, I just want to leave these few thoughts with you around confronting systems and structures. It is not enough for us just to create equity, which is around the tools and really customizing the tools for certain populations or individuals that you may come across in care that may need additional support because enough access is not, or enough of the apples are not available in their domain. What we need is both equity and justice. And justice is about fixing the system. So it's about changing the trajectory of the tree that is bent and making it upright so everyone has the same equal opportunity. And so we do that by fixing our policies, by confronting and taking on the barriers of our organizations, by taking risk of talking about the hard pieces in these conversations, and really around being advocates for the populations, and particularly in this case, Black and Brown individuals who we are seeing every day receiving lower quality of care and having lower outcomes in our data and stratified outcomes. We also want to confront words and actions that may reduce individuals or reduce populations that cause health disparities. And so this is around acceptance of identity and phrases that you see really in the middle of the slide. So I don't see color. is a prominent one that you may hear that has been used in the past and really is a phrase that people may feel is okay to say, but it's really a dangerous thought because when we promote racial colorblindness, we silence and make invisible the Black and brown bodies, the experiences, their lives, and their traumas. And so we don't want to do that. But in fact, we want to see something about individuals. We want to appreciate their individualism. We want to see their struggles and not minimize them. And as we think about this, being actively aware of their race and their race-based inequities will help us to get there. So it is important for us to acknowledge and honor everyone's identity. And lastly, as we think about implicit bias and the cyclical nature of how implicit bias plays into structural racism, we must remember that structural racism is a system in which public policies, institutional policies, and cultural representations have worked to reinforce and perpetuate racial group inequity. And so when you continue to bring in those pieces around bias and not take on understanding what your biases are and work to change those, you are creating more of the cyclical spin around how we have negatively and continue to negatively impact history, policy, and practices. And so we want to really change that and reduce that to really impact our populations, impact the care they are receiving. And as we know that when we impact overall outcomes related to wealth and well-being, we also impact health and prosperity and generations of others within communities and long-term outcomes. And so with that, I will stop the lecture and move to the case scenario, I believe, Dr. Francis. So I'll just share and then you'll be put into your breakout groups. And so this case is one that I'm sure many of you have experienced in various ways throughout your professional careers. And I thought it was important because there's a lot of discussion often about what to do in care settings or what to do when you are facing this, because it brings up so many aspects of, as we think about cultural humility, as we think about dignity of people, and as we think about how do we address those whom are our colleagues, those whom we work with, and also our patients. And this can be flipped into many different where it also impacts patients. But today we're going to talk about a white male patient on your nursing unit that has been assigned a physician for his chief complaint and clinical presentation. The physician, a Black male from Nigeria, goes in to greet the patient and assess his condition. Upon leaving the patient's room, the charge nurse enters to check on the patient. The patient states to the charge nurse, "Can I please get a white doctor from America who I can understand? He is not qualified to take care of me, and I don't want him." The charge nurse validates the patient's feelings, stating that she understands his concerns and that she would speak with her nurse leader about changing his assigned attending. When the charge nurse approaches you as a nurse leader, you reflect on the following questions to respond to her request. How would you approach the situation? What essential elements of the dignity model would you apply? What elements of cultural humility are missing in this situation for both the patient and the charge nurse? And how could the charge nurse and the nurse leader be allies in this situation? And so I encourage you not only to think about this from the scenario, but I encourage you to think about it from your personal experiences that you may have had over your professional career or ones that you've had in your community interactions. And I'm sure that will really help you to bring thoughts into this conversation in your breakout sessions.